live stream to the downtown campus.
I literally didn't know this place existed until like about an hour or so ago. So,
Well, now you do. Here we are.
true.
It was nice to meet you.
Oh, good to meet you as
Kathy,
well.
by the way.
Oh, Marita Grant. Nice to meet you.
Speak really loudly.
Okay. So, good afternoon. Hello. Good afternoon. My name is Marita Grant, Dr. Marita Grant, and I'm an associate professor at the University of Alabama, Birmingham, Department of Psychiatry and Behavioral Neurobiology. And I'm here to speak with you this afternoon about depression and anxiety in primary care settings. So I'll start by pointing out that I have no financial relationships to disclose regarding this talk. So what I'd like to do today is to give you a broad overview that can help to address some of the questions you may have regarding your patients who present with issues related to mood or anxiety disorders. So the learning objectives for this afternoon are to review diagnostic criteria for mood and anxiety disorders, familiarize you with standard assessment tools that'll benefit you in terms of identifying patients who may be appropriate for treatment, reviewing measurement-based treatment to target approaches, and giving you an overview of coordination of care with a collaborative team. So to begin with, over the course of the lifetime of the average adult, mood and anxiety disorders are actually pretty highly prevalent. So for instance, if you look at mood disorders, roughly in adults between the ages of 18 and 59, mood disorders tend to occur in anywhere from 1 in 4 to 1 in 5 adults. If you look at anxiety disorders, they're actually even more frequent and occur in 1 out of 3 adults. And notice that you have that peak period of time between the ages of 30 and 44, where it tends to peak, so that you have 1 in 4 adults presenting with mood disorders, and more than 1 out of 3 presenting with anxiety disorders. Unfortunately, most of these illnesses tend to go both unrecognized and untreated in primary care settings. So between 25 to 33% of patients treated in primary care settings will end up meeting criteria for psychiatric disorder. The most common of these, as I said, will be mood disorders, anxiety disorders, but also substance abuse disorders. And that tends to constitute up to about 20% of those individuals that you'll see. However, upwards of half of those patients will go unrecognized and therefore untreated. Subsequently, what's happened is that primary care settings have become the de facto mental health care system for most adults in the US. So notice, first of all, I don't know if I can reach that over there, but roughly 60% of these individuals will simply never receive any treatment at all. As I said, they'll go unrecognized and untreated. The other roughly 40 to 41% who do receive care, for the most part, they will not receive care from someone like me, who is a mental health specialist, but instead typically will receive care in a general medical setting. And so over 50% of individuals who do receive treatment will do so in a general medical setting. So I want to talk for a moment about what exactly constitutes a mood disorder. So mood disorders are characterized by serious change in mood that causes some sort of disruption in life. And what I mean by that is not simply that someone is presenting with symptoms, but does it actually impair their ability to function in their life? There are different subtypes of mood disorders that generally fall into about 3 categories. There are those individuals who will present with what's referred to as a unipolar depression, right? They're simply depressed. There's nothing else going on. Individuals who will simply present with mania, where they have this elevated mood, and then individuals who fluctuate between those two, and that's bipolar disorder. They'll have periods of time where they feel depressed and down, and other periods of time where their mood is elevated. Major depressive disorder is typically characterized overall by a depressed mood for a majority of the time, right? So consistently over a 2-week period. And often people will ask, well, does that mean that they have to be depressed every day for a 2-week period? No, it doesn't. It means that they have to be depressed for most of the day, most of the time over that 2-week period, or something called anhedonic, where they've lost their ability to enjoy things that they would normally enjoy. In terms of mania, it's just the opposite. The person will have a very elevated mood, maybe highly self-confident for some period of time, and then it levels off. And of course, for people with bipolar disorder, they'll fluctuate between the two. There are differences with regard to subtype and severity, but that basically constitutes mood disorders. In the case of individuals with bipolar disorder, you may have some who rapidly cycle through periods of depression and periods of mania, or those who do so more slowly, but it still constitutes the same disorder. In terms of what constitutes anxiety disorders, this would be this sort of increased worry or fear. Again, it's not temporary. It tends to persist. So in someone, for instance, with generalized anxiety disorder, there may be about a 6-month period where they're in this heightened state of anxiety. So generally, the idea is that the anxiety does not go away, and typically it tends to exacerbate over time if left untreated. Again, importantly, similar to mood disorders, there's some impairment in function. Typically what we look for are impairments in job performance, school or work, or their interpersonal relationships. And there are several types of anxiety disorders, the most common of which, as I alluded to, are generalized anxiety disorder. These are people who just tend to worry a lot about various things. Panic disorder, where the patient will tell you that they suddenly felt as if they just had this rapid onset of fear that was overwhelming. They may think that they're having a heart attack, that they're going crazy, that they're about to die with this rapid onset of fear. And of course, phobias. That can range anything from a simple phobia, for instance, a fear of spiders, which I would put myself in that category, to something more complex, such as social anxiety disorder, where they're very uncomfortable in social settings. It can be in a work setting, it can be in their interpersonal life, but they're just very uncomfortable in social settings. So how do we assess this then and employ measurement-based care? So the idea behind measurement-based care is something that you actually already do pretty typically in most of your practices, which is this idea of clinical outcome measures being repeatedly assessed, right? So if you get someone's blood pressure repeatedly, you're basically engaging in measurement-based care. Unfortunately, similar measures of behavioral health have not been employed in primary care settings. So standardized measures that are being repeatedly provided to your patients to determine both their baseline status and then how are they doing in terms of the trajectory of illness. And these measures are useful in that they can identify individuals who may otherwise go unrecognized in terms of their need for healthcare services. The most important issue, however, is that you utilize measures that have been standardized. And so to that end, I want to go over some standardized measures that you can use in terms of your own individual practice. So I want to start with something called the PHQ. And the PHQ is a patient healthcare questionnaire. One of the difficulties, as it turns out historically, with getting these sort of standardized measures into primary care settings is that they were typically clinical interviews. And clinical interviews really do need to be done by mental health care professionals who have a background in that field, the additional knowledge to present it. The PHQ was developed out of something called PRIME-MD, but it's just a self-report measure that you can just give to your patients and have them fill out. And it assesses the presence or absence of mood disorders. And it's actually useful in that it literally is the criteria from the DSM, from the Diagnostic and Statistical Manual, the DSM-5, with regard to the criteria for mood disorders. And again, you'll notice that I mentioned it is this question of, are these symptoms present for a 2-week period most of the time? So the first two questions, little interest or pleasure in doing things that you would normally enjoy, that is the definition of anhedonia. And of course, the second question, are you feeling down, depressed, hopeless? If in fact you were doing a clinical diagnostic interview, patients would have to meet criteria for those first two symptoms. Those are considered the A criteria for making an actual diagnosis of depression. In the case of the PHQ-9, that's not a necessity, but you do look for those to be present. And they have it categorized so that the symptom is either not present at all, has been present for several days, or as you get into diagnostic criteria, more than half the days or nearly every day where they've experienced these symptoms. And so it walks through what are typically the 5 out of 9 criteria that are necessary to meet the criteria for depression. So do you have trouble falling asleep or staying asleep or sleeping too much? This is pretty typical of depression. People will report either initial insomnia, where they have difficulty falling asleep, middle insomnia, where they wake up in the middle of the night and have difficulty falling back to sleep, early morning awakening, where they just wake up very early in the morning and can't fall back to sleep, or hypersomnia, where they're oversleeping. They may do daytime napping. Feeling tired, fatigue, also consistent with being depressed. Either poor appetite, they lose their appetite, or hyperphagia, where they're just eating all the time. You notice them putting on weight. Low self-esteem, feelings of guilt for things that they have or haven't done, trouble concentrating. Often patients will talk about having difficulty with sustained attention. They'll talk about having difficulty remembering things, so impaired cognitive functioning. Moving or speaking more slowly than they normally would, but it needs to be something that's actually noticed by others, not simply the sense that they are slowing down, or just the opposite, where they're hyper, fidgety, moving about a lot. And then last but not least, the most important question on there are they having thoughts that they would be better off dead, or thoughts of hurting themselves in some way? Again, obviously if they report 0 on that, there's nothing to be concerned about. If they report a 1, there's something called passive ideation, where you just kind of wish that you weren't here right now, or you think to yourself, maybe people would be better off without you. That's less of a concern. What's more of a concern is if they say more than half the days or nearly every day that they are thinking about harming themselves. That's when you need to consider getting additional help for them. And the next set of criteria, again, does it impair functioning? So if you checked any of these problems, how difficult have they made it for you to do your work? And again, that's this section down here, is impairment of functioning. Fortunately, with the PHQ, that area that's in the blue that I've circled, I can't reach it from over here, so I just went ahead and circled it for you. Those actually are, they provide you with a range that tells you basically what the proposed treatment action is. So if it's 0 to 4, do nothing. The person is perfectly fine. If it's 5 to 9, you want to do something called watchful waiting, where you simply repeat the measure the next time you see them. That would be in the mild range for depression. If it's 10 to 14, that's a more moderate range, and you want to consider doing something such as a standardized intervention, such as cognitive behavioral therapy, or some form of pharmacotherapy. If it starts to get up to the 15 to 19 range, now you're getting into more severe range with regard to depression, moderately severe, in which case you want to employ some sort of immediate initiation of either pharmacotherapy or a non-pharmacological intervention like CBT. If it's 20 to 27, you're now looking at somebody who's pretty severely depressed. They tend to be more obvious overtly, even when you see them in your office. And there needs to be some immediate initiation of pharmacotherapy or CBT, something along those lines, but also to make a referral to a mental health professional. So that's the PHQ. And by the way, feel free to ask questions as I'm going through this if things come up. So the next measure then is a measure of anxiety disorders. And this is something called the GAD-7. This is for generalized anxiety disorder. And in the case of the GAD-7, it's very similar to the PHQ-9 in that you have 7 criteria for generalized anxiety. Again, to what extent are these symptoms present over the past 2 weeks? Does a person report feeling very nervous, anxious, keyed up, being on edge? Are they not able to stop worrying? And when I say that they worry, I don't mean just like a little minor worry about things that are going on in their life, but this is more persistent. They're constantly worrying. They have difficulty turning it off. And often they're worried about more than one thing. So they'll mention multiple issues that they're worried about. And they may seem minor to the average person, but they're incredibly worried about it. Do they have trouble relaxing? Often they'll talk about a lot of muscle tension, maybe tension headaches, etc., but just have difficulty generally relaxing. Are they so restless that it's hard for them to sit still? Again, that's something you might observe when you're interacting with them. Are they easily annoyed, quick to become irritable or angry? This is often present in terms of their interactions with their spouse or their interactions with their children. They're snapping at them, just this irritability. And then last, do they have this feeling of fear that something awful is about to happen? This is sort of this sense of doom. And again, it also assesses impairment in functioning, and then they provide you, again, with the range of scores and the proposed treatment. It's slightly different from the PHQ in that 0 to 5 is not of concern, 6 to 10, more mild, watchful waiting, 11 to 15, consider doing an intervention, and then 16 to 21 constitutes a much more severe illness. And so the last measure that I wanted to add in is something called the MDQ. And this is the Mood Disorders Questionnaire. It's actually a measure of bipolar illness. And the relevance of the MDQ is that if in fact you are seeing someone who has bipolar illness and you decide to treat them yourself with an antidepressant, the issue with that is that if you have an unrecognized bipolar illness, you can actually kick that person into a manic state. So you want to be clear that you're actually dealing with unipolar depression and not a bipolar illness that you've missed. And so the MDQ is really useful for that. Again, it's a one-page self-report measure. It has 13 questions. Typically, what you're trying to find out is has there ever been a period of time when the person was not their usual self, and they noticed that they were feeling either really hyper, self-confident, they may be more irritable than usual. Often what you'll notice when you interact with the person is they're incredibly talkative. It's something called pressured speech. And it kind of gets a little bit of a bad rap on television because it's often presented as the person just speaking incredibly rapidly. It's not that they're speaking rapidly, it's that they're speaking incessantly. So often when someone is bipolar and they present to my office, what happens is I ask them a single question and I can't get a word in edgewise for about the next 15 minutes or so. they're literally just talking and they're going from one topic to the next. And that's because in their own head, they're having racing thoughts and they're literally verbalizing the thoughts that are racing through their head. And so they'll just go from one topic to the next and they'll just continue to talk until you cut them off. These people may also be hyperproductive. You may notice, or they may mention, for instance, I've had patients who were up in the middle of the night starting new businesses, calling friends, just very active at night. They don't require very much sleep, which is the most overt symptom that you'll recognize, is that they may tell you that they've only gotten 2 to 3 hours of sleep. They are not fatigued. They feel perfectly fine. If anything, they have an excess level of energy and appear to not require much sleep for a period of time. They might also do risky, impulsive behaviors that are not typically characteristic of them. So if they meet criteria for 7 or more of these 13 items, and they also say that these items occur in a sort of cluster together, and it impairs their functioning between moderate or serious, you're actually looking at bipolar illness. So you just want to make sure that you're aware of that, that you don't inadvertently treat someone as if they have unipolar depression, who actually is bipolar. So in terms of treatment to target, the ability to adjust your treatment plan based on symptom measures is one of the most important elements of doing this collaborative care. Typically what we're looking for is a 50% reduction in measured symptoms. So, the next time, over the course of time as you're treating your patient, what you expect to see is a reduction in symptoms as you're repeatedly assessing them. 50% would be, let's say that the person came in initially on the PHQ, they had a 26. You're trying to get them down to about 13 to determine that they're something called a responder. This is not the same as full remission. Full remission means that they've dropped under a certain set of criteria for that particular disorder. If they were doing like a clinical assessment like the Hamilton Rating Scale for depression, they would have to have a score of 6 or less. That would be somebody who's fully remitted. What you're looking for are they actually responding at all to the treatment that you're providing? And with this repeated measurement of symptoms, what you hope to see is somebody who either fully remits or at least is a partial responder. The concern is when there's no response to treatment, in which case this is indicative of a need to either shift treatments or try something in terms of an adjunct. So this is the information that's important in terms of deciding what to do in terms of treatment. And so this is just a sort of general algorithm in terms of the process for evaluating and treating individuals who present with mood or anxiety disorders. So for instance, you start off with something like the PHQ to determine the presence or absence of depressive symptoms. If there are minimal symptoms, can't see that over here. If there are minimal symptoms, which is to say it's less than 10, you can provide some supportive information, education, follow up with them in about a month. If the symptoms worsen, or the person comes in initially presenting with a PHQ score between 10 and 19 or exceeding 20, what you want to do is refer them for more comprehensive clinical evaluation by a mental health specialist in the particular area of concern. Determine appropriate treatments if you plan to treat them yourself. The use of an antidepressant, or if they're bipolar, mood stabilizer, or something that is actually non-pharmacological, such as a standard intervention like cognitive behavioral therapy, and then carefully monitor treatment adherence, drug efficacy, safety, etc. If you have someone who actually says yes to question 9, to that issue about suicidality, and again, not simply, I wish I wasn't here, things along those lines, but who are truly meeting criteria, you need further evaluation. Determine if the person is safe. And if they're not safe, get them to the emergency department. And what I mean by not safe is not simply that they are reporting this sort of mild passive ideation, but they're conveying something to you that conveys intent and a plan. And what I mean by that, intent is something along the lines of, if they have no reason to go on, they're planning to end it, to just bring all of this to an end. Do they have a specific plan? So the first thing that we always assess is, do they have access to some weapon that they could actually employ to harm themselves? Do they have access to other means? Are they taking medications such as pain medications where they could overdose, et cetera? Get those away from them as soon as possible, or them away from that. But the first thing you want to do is just assess that and get them into the appropriate care, which is typically, for our purposes, get them to the emergency department where they can get more specialized care. Okay. So what then is the impact of these comorbid behavioral health issues? So in another lifetime, before I finished my PhD, I actually, before going into clinical neuroscience, I actually did health psychology. And so when I was a grad student at Duke, I worked in a sickle cell clinic treating patients with sickle cell. And one of the first things that we looked at was this relationship between stress and pain. And I subsequently kind of moved away from that and more into clinical neuroscience. But it turns out actually that there's this relationship between the prevalence of medically unexplained pain and mood disorders that go unrecognized. And so just generally, how many of you tend to see patients who have unexplained pain? Anyone? No? Okay. So Aguera et al. Looked at this relationship between medically unexplained pain and unrecognized mood disorders across multiple primary care settings. And I think there were roughly about 3,100 or so patients involved in the study. And these were people who, when they came in, had no diagnosis of depression. They were simply presenting with some medically unexplained pain. And what they found when they did a diagnostic evaluation with them is that over half of them met criteria for major depressive disorder. Another roughly 16% or so met criteria for a more minor form of depression. It's minor but more chronic, called dysthymia. 1.4% met criteria for bipolar disorder. And only 2.5, actually surprisingly to me, met criteria for depression that was actually caused by the medical condition. In other words, they had some condition that subsequently led to them becoming depressed. So over half of them were simply depressed and subsequently developed some form of unexplained pain. And this seems to suggest that individuals who present typically with chronic pain, often women, what is actually seems to be the underlying issue is actually unrecognized major depressive disorder. In terms of healthcare utilization, you'll notice that this particular patient population actually utilizes a significant portion of the healthcare coverage. So in this population, they looked at the 6 weeks leading up to their presentation for this particular investigation. And what they found was that, can't reach it from over there, the number of primary care visits due to pain in the 6 weeks that led up to this assessment you notice it's almost 4 times higher in individuals with concurrent major depressive disorder than it is in those who didn't have major depressive disorder. So individuals who were depressed were almost 4 times likely to go and see a primary care physician due to this medically unexplained pain. Similarly, they were 5 times as likely to go and see a specialist, to have seen a specialist in the 6 weeks leading up to that point, than individuals who were similarly matched but had no concurrent major depressive episode. And even though it didn't reach criteria statistically for significance, they also were more likely to have undergone tests to assess pain, as well as a higher number of hospitalizations due to pain. And so this is not to suggest that they don't have any underlying issue that might be driving the pain, but often it's either exacerbated or can be actually driven by major depressive episodes. And in part, I suspect that this has to do with the fact that areas of the brain that mediate the sensation of pain and the expression of pain are also the same areas of the brain that underlie the expression of emotional pain. And that this may just go undifferentiated in our brains, basically. Similarly, when looking at anxiety disorders, so Spitzer, back in 2006, in terms of developing the GAD-7, looked at this relationship between that score, the number of disability days, and symptom-related difficulty in clinic visits, again, in a primary care setting across multiple sites. And what they found was as the level of generalized anxiety increases, so do the mean number of disability days where the person is unable to perform at work, falling into this category of disability. The mean number of physician visits also increased, as well as symptom-related difficulty in terms of their perceived ability to function. So again, in summary, this both depression and anxiety can subsequently significantly impair functioning, but also increase healthcare utilization. And you have patients who are presenting with chronic illnesses that seem difficult to treat when, in fact, it's typically because it's more mental health related than necessarily physical. Okay. So, in terms of treatment, there are basically sort of just 2 primary approaches. There's pharmacological and non-pharmacological. On the non-pharmacological end, this is typically what I do as a clinical psychologist. For both mood disorders and anxiety disorders, most of them are responsive to standardized interventions. Cognitive behavioral therapy is actually the most well-researched, well-disseminated form of intervention for dealing with mood and anxiety disorders. Any of you familiar with CBT? Oh, I see a hand. Okay. So the basic idea with cognitive behavioral therapy, after developing a rapport with a patient, there are these 3 elements. There's psychoeducation, there's cognitive, and there's behavioral. And what I mean by psychoeducation is most people are not familiar with CBT. And so there's you have to provide a rationale for why are you doing this thing that you're doing. It's not the same as supportive psychotherapy. The idea with CBT is that other people and events don't cause our emotions. If in fact other people and events could cause our emotions, anytime something happened in the world, we'd all feel the same way about it because the event would be causing our emotions. And obviously we know that's not true. If you got 10 people in a room together and ask them all about the same event, you get 10 different perspectives on it. And so this idea with CBT is that there is this relationship between our thoughts, our feelings and our behavior. And that is to say that our thoughts are what actually generate our emotions. And then our emotions actually facilitate or are intended to facilitate adaptive behavior to our environment. So for instance, if you experience fear, it's intended to get you to engage in life-preserving behavior that is facilitating an adaptive response to your environment. In individuals who are anxious, anxiety is similar to fear, but it's not the same. It's mediated by some of the same areas of the brain, but not exactly the same. The problem with anxiety is that it's in response to a perceived threat that doesn't necessarily exist, and subsequently elicits behavior that is consistent with an actual threat, where there would be an acute response such as fear, but it's more persistent. It just persists much longer than fear, and it's not adaptive. And so subsequently, it generates behavior that would be consistent with an actual threat. So behaviors such as avoidance, right? So that you can protect yourself from the perceived threat. So that's typically what we do in terms of providing the rationale. In terms of the cognitive component, the idea is to teach the individual to basically self-monitor their own automatic thoughts. And what I mean by automatic thoughts are things such as, I must be stupid, I'm going to fail my exam. Literally everyone has an ongoing conversation with themselves in their head. Our brains want to communicate. And if we have other people around to communicate with, we talk to other people. When other people aren't around, or if we're anxious or depressed, we're having a conversation with ourselves in our own head. And it matters what you're telling yourself. If you are telling yourself things like, I must be stupid, what kind of emotion would that elicit, right? The person might tend to feel down. If they tell themselves that they're going to fail an exam, it might elicit anxiety, right? There's a fear of what may happen. And so we teach them to recognize that conversation, to self-monitor it, and to challenge it when the beliefs are false or there are cognitive distortions. And it's basically, it's kind of a Socratic questioning in terms of what is the evidence that their belief is accurate versus what is the evidence that it's false. Subsequently, the last component is the behavioral component. And the behavioral component is actually getting them to generate and employ problem-solving strategies. Often, as it turns out, people are depressed because they have poor problem-solving skills. They find themselves with a problem and they're unable to resolve it. And initially, this elicits anxiety, and if it still goes untreated, it subsequently elicits depression. So we teach them to generate and employ more effective problem-solving skills. We also teach for anxiety disorders, employ graded exposure. Exposure is just basically the idea is extinction. You learn to fear through classical conditioning. You can learn not to fear through a process of extinction. And in addition to that, also relaxation techniques, et cetera. And so that's the behavioral component of it. And it usually takes about 12 to 16 weeks. And with repetition, just changing how you perceive events, which subsequently alters how you feel about it and subsequently alters your behavior. So. Now, I did decide to include a slide on medication management, acknowledging this is not my area of expertise, but because I knew you would have handouts, just so you would generally have that information. It just gives you an overview of some of the SSRIs as well as SNRIs that are typically employed in treating depression and what some of the advantages and disadvantages are of utilizing these particular medications. I'm not going to go into it too much. Again, this is outside of my area as a clinical psychologist, but for those of you who will be prescribing, this can be useful information. So in terms of the actual effectiveness then of cognitive behavioral therapy and antidepressants, they're actually pretty similar in terms of efficacy. So this is a classic study from Rob DeRubis and Steve Holland, excuse me, looking at the comparison between cognitive behavioral therapy and antidepressants. And what you notice is that in the first 8 weeks, I can't reach over there, in comparison to placebo, they're both pretty effective, but antidepressants just have a more rapid effect initially. So it actually is important, the rate at which someone recovers, because each day that they haven't gotten better, they continue to suffer with the sort of symptoms associated with depression, and in particular, if there's an issue with regard to suicidality, that can be an issue. That being said, it's not that CBT is horribly different. It's still at 43%. It just doesn't work as quickly. However, as I said, it's about a 12 to 16 week intervention. By the time you get out to 16 weeks, they're pretty comparable in terms of response and remission at that point. So I say that to say it doesn't really matter which way you go, except the initial rate of recovery with antidepressants, the rate of remission is slightly faster. In terms of relapse prevention and actually preventing your patient from relapsing, CBT is actually typically more effective in that you're literally teaching the patient a set of skills so that even when you discontinue the intervention, they have a set of skills so that the next time some issue presents, they actually have a set of skills to address it. Okay. So just want to revisit that issue of suicidality. When we think about suicidality, we tend to associate it just as a general thing with depression. Suicidality is not limited to individuals who are depressed. There is a significant suicidality rate, for instance, associated with psychosis, people who are schizophrenic, with substance abuse disorders. But often what's overlooked is the suicidality that's associated with anxiety disorders. And so this study actually looked at suicidality in primary care patients. And these are patients who met criteria for at least one anxiety disorder of moderate severity. And I just wanted to go through some of that classification. So within this population of patients who were presenting in a primary care setting, 25% of them had, basically said yes to the question of thinking that they were better off dead or wishing they were dead. This is what I mean about passive ideation. It is simply, you can think of it as almost wishful thinking. I just wish I wasn't here. This is really difficult. It's hard. People would be better off, maybe if I just weren't here. That's passive ideation. Wanting to harm yourself or to hurt or injure yourself, 5.1% endorse that. That's something that's known as non-suicidal, self-injurious thinking. The intent, again, is not to kill yourself, is not to actually die, but it's this self-injurious behavior. Often you see this in patients, for instance, who meet criteria for borderline personality disorder. They are not intending to harm themselves in the sense of trying to commit suicide. There's a paradoxical effect, in particular in people with borderline personality disorder, where actually injuring themselves actually decreases their level of distress, which seems, paradoxical. That if you cut yourself or burn yourself or hit your head on something, it seems like you would be in a great deal of pain, but it actually decreases their distress. The problem, of course, is that when you are cutting yourself, you might accidentally get it right if and you might actually end up committing suicide unintentionally. But that particular question just goes to whether or not they were having those kind of thoughts. 13.4% were actually thinking about actually committing suicide. So these are people Again, these are people with PTSD, generalized anxiety disorder, panic disorder, social anxiety, et cetera. And there's still this significant rate of suicidal ideation. Then there's actually deliberately harming, injuring yourself. And again, that's the non-suicidal but self-injurious behavior. So these are people who actually acted on those thoughts, who are actually doing self-injurious behavior. They don't necessarily have to be hospitalized. This is probably not a population that you will necessarily want to treat. You may go ahead and utilize referral services because they're a little bit more complicated. Again, they don't necessarily require hospitalization. I tend to treat borderlines on an outpatient basis, but we have a contractual agreement with regard to self-harm. But they are going to engage in self-harm behavior. And typically they'll hide it if they think that you're going to hospitalize them because their intent is not to actually commit suicide. And then that last group, the 17.8%, are the group of people who over the course of their lifetime have actually made a suicide attempt. So these are the people who actually meet criteria for an anxiety disorder who've actually made an attempt. And so this is what I mean, that there's this general idea that, if somebody attempted suicide, they must be depressed. But not necessarily. Other disorders are associated with suicidality as well. Okay. So, the last thing I want to address is the collaborative care approach. And, so this is you and this is your patient. The first thing, of course, is establishing a trusting relationship with the patient. There is still a certain amount of discomfort for most people in terms of acknowledging any sort of psychiatric issue. Even when they're going to see their primary care physician, the focus is, I just have this problem, I need you to treat it, not, I'd like to tell you about, the fact that I'm depressed because I'm getting a divorce or something. And so establishing a trusting relationship with the person to get them to open up with you is the first part of this process. Then there is that guided assessment that I talked about in terms of using things like the PHQ, the GAD-7, the MDQ, in terms of actually assessing what's going on with them. In terms of the protocol, you basically want to go with what you're comfortable with and what the patient is, their preference. So what is it that you are trained to do in terms of treatment? Are you comfortable in terms of prescribing antidepressants, anxiolytics, whatever the case may be? Are you uncomfortable? By all means, make the referral. That's what we're here for. What does the patient want? So often the people that I see are patients who may have come in through primary care at UAB, but they don't want to be put on a medication. They have fears about medications of all sorts, and their preference is to be treated with some form of therapy. Other people prefer not to discuss what's going on in their life, and they just want somebody who will prescribe for them. And so it's partly the match between your comfort, your training, and what the patient is seeking in terms of care. And if you do make the referral, typically what happens is, this would be me over here, in terms of the behavioral health. We do an intake evaluation with them. I typically see patients anywhere from weekly to bi-weekly, so there's a fair amount of interaction. We make our notes available in the electronic health record system, so they are accessible to the referring clinician. As well, they can be referred to the psychiatrist. They tend to do med management on a less frequent basis. They initially see them, prescribe, and then just kind of follow up with them in terms of anything that's happening, in terms of side effects, do they need to titrate, et cetera. And so that's basically the process in terms of coordinating care. So that is it. And don't forget the worry or pose. So, questions?
Yes. Would you discuss in relation to anxiety, people who have premonitions about bad things that actually happen?
Huh.
It's not a thought, but it actually happens.
So they have a premonition about something?
An anxiety that such and such will happen, and then it actually happens.
Oh.
I was in Oslo, Norway one time, and had a flight to Bergen, and I couldn't sleep all night long. I was real anxious at the airport, and it came into my mind the plane was going to crash.
Huh.
So I was going to tell them that the plane's going to crash, and I thought, that's not too wise. They'll arrest me immediately.
That's
so
true.
I actually changed my flight and went to Copenhagen instead. And the next morning, I was looking for American newspaper, English newspaper, to see if the plane had crashed. The plane had not crashed, but the hotel I was to stay in Bergen had a fire that night.
Wow.
There were 42 foreigners in one wing, and I would have been one of them, and all of them died in the fire.
Oh, wow.
Now, that was a premonition that something terrible was going to. It was so severe that I canceled my flight in 2 weeks' time on a vacation.
Huh. I suspect that probably is a coincidence,
I've
but,
had 4 episodes in my lifetime
oh, wow.
of things that actually happened.
I suspect that if you are worrying about things that happen, so for instance, have you worried about things that happened and then nothing happened?
Very seldom.
Oh, okay. I was going to say, because if you kind of consistently worry, eventually something does actually happen.
I was worried about having a car wreck leaving this hospital last year, and I kept worrying about it, and the traffic stopped, and a woman ran into the back of the car.
Oh, okay.
And these things have actually happened, I thought.
Yes.
Does everybody
Does everybody?
have premonition?
No, but anxious people tend to anticipate threat in the future. And so they tend to think about that often, that something bad is going to happen in the future. I have to say premonitions are outside of my purview, but I could see how, if you're anticipating that something may happen.
If it lasts more than a couple of hours, then I take it seriously. If it doesn't, then I assume it.
Then you let it go. That seems reasonable. But yes, I have to say premonitions are a little outside of my area of expertise. So, other questions? Thoughts, concerns? No? Okay.